Hiya, thanks for inviting me to talk today. So I've been asked to talk about, first of all, our guideline changes within secondary care and how this is in line now with the new Tier 1 Welsh Government target for trying to increase our narrow spectrum use of antibiotics. And then the second half of my talk is just about the work we've been doing in CumTAF with the public about trying to improve their knowledge with antibiotic resistance. So first of all, if we look at the secondary care formulary changes that we undertook, back in 2014 when I first started, CumTAF were the highest prescribers of Comoxclav in Wales, and we also had 60% resistance in E. coli bacteremia isolates to Comoxclav. So there was something we really needed to do about this, because obviously Comoxclav wasn't going to work in our patients anymore. So we decided to remove Comoxclav and meropenem from our guidelines, and we introduced cotrimoxazole, teicoplanin and gentamicin. And we used a lot more of 3-drug regimes rather than 1 drug fits all. And we developed the intranet and app guidelines, which is new for us, and we obviously update our surgical prophylaxis guidelines. To do this, we did some grand rounds and pharmacy meetings, and we went down to A&E as well, and went to each department meetings as well. And obviously had to do more junior doctor training around gentamicin, as they all hated prescribing this drug. So if you look at where we took it out, so we had to use, instead of just using Comoxclav now, we had to use maybe 3 drugs in some cases. So we're using like benzyl, penclorythro and gent in our severe CAP patients. We've gone over to Tyke and Gent for HAP, and then we've added in cotrimoxazole then for some of our intra-abdominal infections. Instead of TAZ then, we've had to go over to like a Mox and Gent for complicated UTIs, and then for diabetic foot, we're using Fluclox and Met and Doxy as a different alternative. And again, for intra-abdominal sepsis, we've gone from amoxicillin, metronidazole and gentamicin. So we completely removed it from the common infections you'd see. So if you look at the graph, our guideline change happened in 2014. So we were using about 65% of antibiotics were low risk, but we were using 35% were high risk for C. diff. As the years have gone on and compliance has improved with the guidelines, you can see we're now up to 84% low risk antibiotics and only 16% are classed as high risk. Obviously this will never be zero. Comoxclav is still a really good antibiotic, and it definitely has its place within treatment with our patients. But obviously trying to reduce the amount we're using it and saving it for those patients that need it is what we need to be doing. So if you have a look at our trend then, Comoxclav reduced nicely, and as you can see, it didn't have much of an impact on our cephalosporins, clindamycin or quinoline use. They're all quite static still. There was no huge increases in those. If you look at our TAZ and carbapenem use, so I think some people will worry that if we remove Comoxclav, people will just go for TAZ and meropenem instead. But as you can see, we're well below the All Wales average for our use of those. And in Prince Charles, well, our carbapenem use has actually decreased as well. One of the other impacts the guideline changes may have had, we can't say for definite, is our C. diff cases also fell and have still reduced since our guideline changes within 2014, which is great to see as well. It obviously came with its challenges because we were introducing a drug which hasn't been used for years and everybody was very against it coming back. It obviously took a lot of time as well. There were some consultants which were harder to change than others. And I think the way we approached it, first of all, could have been better. We sent out consultation via email, expecting busy consultants to read it and reply. So I think taking that on board now, we go to each speciality and directorate meeting and actually talk about their guidelines within that, and then they can comment them face to face. And it's definitely better because they feel a bit more ownership over the guidelines. We also do antimicrobial ward rounds now with them, trying to make sure that they are complying with the guidelines. And I think the fears of cotrimoxazole and gentamicin definitely has decreased and is definitely getting better. And if you look at our use now, people are definitely using it more, so in line with our guidelines as well. So that's a quick bit on our secondary care guidelines. So another bit of work which we're doing within CumTAF is around trying to change people's beliefs around antibiotics and how they use them and what the whole antibiotic resistance means. So we decided to set up some antibiotic myth-busting sessions. So it came about when we were feeding back to GPs about their antibiotic prescribing. We found that some of the population within CumTAF are still quite demanding for antibiotics, and that's what they expect when they walk through the door. So we thought, is there something we can do about this and maybe educate the population within CumTAF? So we came across the Wellcome Trust study, which looks at patients' views on antibiotics and what they think about the terms antibiotic resistance and superbugs. And we used this study to develop the session. And we contacted our local community network teams and to put us in touch with local community groups. So we were going to already existing groups out there. So our aims for this were to engage with the public about stewardship issues and dispel myths around antibiotic use and what resistance actually is. We were then a point of contact. We could answer any questions they had regarding antibiotic use and resistance. And obviously we wanted to change behaviour, but we know one face-to-face session isn't going to result in this, but it was definitely a start, and it was giving us information and invaluable results really of how we can take this forward within CumTAF and how we can expand on what we're already doing. So the sessions are delivered by our antibiotic tech, Amy, and it's a short PowerPoint presentation. It just gives a short introduction on bacteria, viruses and antibiotics. And then the main bulk of the session is a true or false game. So every participant has a paddle. One side has true on, one side has false on. And they're given a statement taken from the Wellcome study. So, for example, antibiotics only kill the bad bacteria and all the good bacteria survive. They then have to put their paddle up if they think it's true or if they think it's false. And then Amy will explain why the answer is what it is. And it gets a discussion going then within the group. So that's one of our groups there as well, who we were delivering it to. A lot of our groups are the elderly population because of the time of day we're doing it. They're within work hours, but Amy has been to some out of work hours, which are capturing a younger audience then. So after the session, then they're provided with information on managing your infections yourself. So gives them how long they think the infection should last and what they can do at home. They're given a packet of tissues with a message just to remind them that antibiotics don't work for coughs and colds. And then they're given Your Medicines, Your Health and antibiotic pens then as well, just as a little freebie. So to evaluate the sessions, we ask them to undertake a pre and a post questionnaire. So it's made up of 4 Likert-style questions and 3 triad questions. And then this is all entered after into a computer system called SenseMaker, which then gives us our graphs. So if you look at the results, it's easier to look at the shift of the red line rather than the axes, because the axes, when you get it out of SenseMaker, change. So I'll explain now. But so one of the questions was, if someone has a cough or cold, the best thing to do is take antibiotics. So before, as you can see, most people did think never, but as you can see, there was a slight shift towards never as well, which is what we wanted to see. As you can see, the red line does shift. So you could see that they definitely learned something from the session, but it was interesting to note that they already knew that they shouldn't be taking antibiotics for coughs and colds. So obviously we need further work here now to look at why is that still resulting in a demand for antibiotics from the GP. Antibiotics are really good at treating bacterial infections. Again, you can see the line shifts the right way, so we want them to be saying that they are good for bacterial infections and obviously not good for viral infections. This might have caused confusion, and I think this is why the shift wasn't bigger, was because within the session, Amy tries to say not to share antibiotics, because obviously you don't know if that antibiotic will cover the infection you have. So I think we need to look at the way we're phrasing that to them, because that might cause a bit of confusion. This was the most significant change, really. I feel confident to explain what antibiotic resistance is to a friend. So before the session, a lot of people felt very uneasy about this, whereas towards the end, then you can see people are moving more towards the confident section. Again, we want to look at these people who still feel uneasy and what can we do within the session to help increase their confidence. And lastly then, using antibiotics all the time can be harmful. So this is a really interesting finding because you can see the shift doesn't shift much. So again, they already know that using antibiotics all the time can be harmful, but why are they still using them when they don't need to be? So again, further work is needed to explore that further. So these are the triad style questions. So they're given a scenario and they're to pick where they think on the triangle is the best option they think themselves. So it doesn't have to be in each corner, it can be anywhere on the triangle. So this one was your friend has a nasty cold with a hoarse cough, which isn't getting any better. You advise them to see a community pharmacist, see a GP or nurse for advice, or look after themselves at home. So obviously we're hoping for the look after yourselves at home. And as you can see, there is a shift slightly after, but as you can see, a lot of people would still go to their GP or nurse for advice. This was an interesting one. So your nephew or grandchild is studying hard for the exams, but has a sore throat, making it difficult to concentrate. You tell them to pop down to A&E, ask their GP for antibiotics, or get throat sweets from a pharmacy. So the majority would get throat sweets from a pharmacy, which is great, but as you can see, there's quite a lot of cluster down to pop them down to A&E. So this is something we really need to be working on and trying to get that message across to patients of where they're choosing to go with what illness they have. After that did decrease, but again, there is still a small cluster in there, which we need to explore further. And then lastly then, your GP has given you antibiotics, but you think you need them for longer. So you should take the antibiotics as prescribed anyway, borrow them from a friend, or space them out to make them last longer. So thankfully, not many people wanted to borrow from a friend after, but again, they were saying take as prescribed, so that was good there. So for future work, we need to revise the questionnaire. Obviously, based on the findings we found, we need to look at the wordiness in the questions and to get better results. And we want to gather patient stories so we can track the patients to see where they're actually moving within those triangles and on the scales. Because at the moment, we can't do that. But by using a patient story, it'll keep it anonymous and we'll be able to track them. We want to target a different age group, as many of our group are over 50. And we want to carry out focus groups now with the past participants to find out what they think of the sessions and how we can develop them further, and also what their views are on antibiotic resistance and things to try and gain more insight into our population within CUMTAF. So we just wanted to say a thank you because we couldn't have done it without 1,000 Lives, Matt and Andy who helped us with the evaluation, and Chris Bolton from Welsh Audit Office for doing SenseMaker for us, and then Maggie from Public Health Wales as well. So thank you very much.